Hi class, stopping in to say I miss you guys, but I do want to give you a little bit of an update for this week. You hopefully have already looked at both lab videos, which we're taping, and we're going to have to do it a little different since the rest of the semester we are going to be virtual only. So this week, make sure you're spending time this week and next week practicing on the different taping videos. You have until next Monday, I believe April 6th, to submit to me a total of 5 pictures. Those 5 pictures are going to give you 50 points. It's 3 for the lower extremity, which would be a picture of your tape job, a picture of your picture of your arch, and a picture of your shin splints. And then 2 for the upper extremity, a picture of the wrist and a picture of the thumb. So you guys are going to have a total of 5 pictures. Submit those to me either via email. My email address is deroloj@mjc.edu, or feel free, if it's easier for you, to text them to my cell phone. I just ask that it be at a reasonable hour. Just because I am an insomniac doesn't mean that I need my phone going off in case I am sleeping. My phone number is 209-679-2224, and you can email me or text me those 5 pictures for your points, and you have until next Monday. Don't forget, by the end of Wednesday, you're supposed to have completed your quiz, and the access code on that quiz is KNEE, K-N-E-E. The K is lowercase. And as always, as soon as you enter in that access code, it's timed for a quiz. You have 15 minutes to complete those questions. And right now we'll get going on upper extremity. Sorry about that. Oh, the joys of making videos, I guess. So for upper extremity, we're going to go over anatomy, prevention of those upper extremity injuries, how we can recognize and manage specific pathologies or specific injuries, and what rehab we can do to help get the patient back into where they were before, or hopefully better. We should be able to identify the major anatomical and functional features of the, why do I have foot, ankle, and lower leg? This is supposed to be upper extremity. Excuse me on that. Discuss how injuries may be prevented and specific injuries of the shoulder, elbow, wrist, and hand. So I have that part right. And then design a rehab technique for those different injuries. And right now we're going to get into some of those different injuries and how they can and do occur. And this is a shoulder dislocation, I believe.
Size them up. Ganner takes a shot over the 7-footer, digs it off the floor. Both are on the deck, and they're going to jump it. Good hustle.
What's Jamal here? We talk about street ball all the time. Over the top. I mean, that stuff you see on videos on YouTube. Well, you know what YouTube is? I got to explain.
Yeah.
I call the internet now.
Internet, yeah. YouTube. I don't like this. Canner looks like he's got that left shoulder that's extended.
Oh, it's this.
Oh, yeah, you can tell. You can tell right on that.
Shoulders out. Yeah.
Shoulders out. And it's going to have to be a timeout. I mean, Canner's a tough one. I don't think he's ever been injured that I know of, and he doesn't know what to think as he really fought for this loose ball.
No, and you love the hustle, but this is where it gets dangerous, is you get your arm under there, and then Hadidi just falls on top of him right here. You know, oh, this could be a serious injury. Because what happens now, you pop that back in, but he might have to miss the time now.
You know, he was trying to get that arm to work, and I don't know if he knew what exactly had happened. Well, you love the fight of this young kid. And his Canner. And Dan Crawford just told Ty, look, if you go full, you know he's done for the quarter, or done for the game. And Ty, you shook his head. Yeah, you know it's out. Oh boy.
The good news would he would just be done for the game, but I just don't see that happening. He's been playing so well too, and getting so much better.
Okay, so you can see that there's an obvious deformity, and to me that looks like an inferior shoulder dislocation. The most common shoulder dislocations occur in anterior, and you're most vulnerable when the shoulder is flexed, horizontally abducted, and externally rotated. Okay, this one was just kind of a tweak incident where the body rolled over and it looks like it pulled the humeral head inferiorly. Okay, this is something that I had gotten off of YouTube several years ago. This person dislocated a couple of her fingers, and they went in, did x-rays, saw that there's no fractures, so now they're going to go in and reduce it. I believe this one is one where they give her lidocaine or something to kind of numb, and we'll go ahead and watch.
We're putting some iodine, which is bacteriostatic, and basically sterilizing the area. We wait till it dries out a little bit before we inject.
Sorry for those of you that don't like needles.
So basically pull back until it feels like it just flows very easy. Base of each finger.
You okay?
Mm-hmm.
You ready?
I'm ready. Do it right at the crease. Finger.
Okay.
Going around it, that's when you know you went into the fecal space.
Do you feel it at all? Do you feel it kind of?
Yeah.
Numbing up?
Feel it numbing or feel pain?
No, I feel it numbing. It feels like kind of thick or something.
Or I should turn it around for us. Yeah.
Yeah, so her
So tell us
fingers
what
are
happened again.
a hot mess.
I was standing, going through some papers. My shoe fell off my foot. I was trying to put it back on, and it twisted, and I fell back and trying to catch myself.
All right. Well, the good news not broke, just dislocated. She's gonna give it a tug. Look how nice. You wonder if it's that easy, why do we have to numb it? Like I said,
Because it's painful.
one, you appreciate it because it's less pain. Number two, the numbing will stay there for a few hours, so you won't have much pain. And that's really it. Like I said, the ligaments have to be really stretched to come to a position that crooked like that, right? So those ligaments are going to start hurting once the numbing wears off. So you want to take Motrin, you want to keep it elevated, you want to ice it, and then we're going to put you in some aluminum foam splints so that it can heal. It's not moving around and stuff.
And going from one extreme to the other. So that last video was in a clinic hospital setting. And here's another one. It's just for fun. Not that I'm recommending anybody try and reduce any dislocations. But this gentleman's on the phone with a friend who happens to be a nurse, and they're telling him how to reduce it. I'm not advocating for you guys to reduce anything by any means. I do know that the quicker it goes in, the less pain there is, but at the same time, there is a high probability. If you do not know what you're doing, you very well can chip or break a bone or have some other ailments to add to your friend's discomfort.
Alright, so grab below it on like alright, so grab the base right where it's dislocated, grab right on top, and then pull out as hard as I can. Alright, so alright.
Kenny, how do you feel? Jordan, how do you feel?
Okay, I'm gonna try this, and you're gonna listen to Jordan. Do I pinch hard? Wait, do I pinch hard with the one that I have the base with? I pinch hard with, right? All right, here it is. 1, 2, 3. Good. Oh shit! That was really easy.
Oops. Sorry about that language. So yes, definitely doesn't need to have the biting the towel or anything like that, but it was just for fun. I don't have any rights or anything to these videos. Let me get the next one loaded. And this one's a baseball MLB broken bone compilation from 2 years ago.
Runner goes. And there's a fly ball, a shallow left coming on to Matsui. Can't make the play. A base hit.
Do you guys see his arm hanging down there? They're going to replay it.
And Matsui is a little shaken up.
You'll see right at the front of his glove, if that slides right there, you're fine. But it caught and actually went back, and it just tears your wrist with it.
Young down the line, now on heading towards Braun, sliding, and he's unable to make the play. No catch there, come on down, moving into the plate, the slide, the tag, out at the plate. And boy, uncomfortable at the plate, Stephen Drew is hurt.
You see right there, that left leg catches the shin guard of Jonathan Lucroy.
Boy, it's really bent backwards.
It's the right. Sherholtz has the best arm. Fairly shallow, more center than right. Cousins is going to test him. Posey can't handle it, and Posey gets clobbered. Posey is hurt, and he never caught the ball. The Marlins are back ahead, and the Giants' only focus now is Buster Posey.
Here comes the throw, and Posey gets clobbered at home plate, and he can't hang on to the ball, and Posey may be hurt. Posey just got destroyed at home plate by Scott Cousins coming in hard.
In 1995, Junior added to his personal highlight reel at the Kingdome. With the Mariners trying to hold on to a 4-3 lead over the Orioles, Kevin Bass hit a shot off Randy Johnson. Out of nowhere, Griffey tracked it down, then slammed it to the wall. But this sensational catch came with a price. Junior shattered his wrist. He missed the next 73 games after doctors inserted a metal plate and 7 screws into the wrist.
Here's the...
Okay, we'll end there. You guys can always go back and click more if you would like. Okay, so first we'll start off with the shoulder. It's a very complicated region of the body in that it is one of the ball and socket joints. So similar to the hip, whereas the hip has a more concave socket and bigger muscles around it, the shoulder, I often liken it to a golf tee and a golf ball. And if you've ever tried to golf on a windy day, how that ball sometimes will roll off that golf tee. So the glenoid fossa isn't as concave, plus the shoulder muscles aren't nearly as big as the hip muscles, so there's a higher probability or likelihood of a shoulder dislocating. Shoulder has more range of motion, as does the hip, and there is a lot of mobility, but it also does compromise some of that stability. You're using your shoulder in a variety of overhead activities related to sports, and you can get a ton of overuse type injuries. So that's one reason why youth leagues are really big on pitch count and not throwing certain pitches, because the adolescents haven't completely matured, and there is a lot of instability in the shoulder. Right here, maybe right here. Yes. So when we're talking about the shoulder complex, what attaches the shoulder complex to the torso is going to be your sternoclavicle joint. Okay. So right here. Okay. We have our sternum, our breastplate, and sorry about that. So we have our sternum, our breastplate, and at the top it attaches the clavicle. Okay, that clavicle and sternum, it's that sternoclavicular joint. So that joint actually has mobility, and it allows the shoulders to protract and retract. So the shoulder going forward and going backward. If that SC joint dislocates posteriorly, that is considered a medical emergency because of all the organs underneath. And if you happen to protract or retract, it could cause harm back there. Then we have our clavicle. It's an S shape, unlike what my little drawing just did. Let me try that again. The clavicle, so is more of an S shape that comes out to the acromion process, and you have your AC joint, the acromioclavicular joint. You have your scapula, or people might have know it more so as a shoulder blade. And what we're worried about with that scapula is the scapulothoracic movement. So in order for you to flex your shoulder all the way up, you get about to 150 degrees, and then after that, the scapulothoracic is going to be able to give you the rest of that 180 degree motion. You also have the glenoid fossa, and then the head of the humerus, which make up the glenohumeral joint, and that's what we're talking about when there are dislocations. Right here we have the bicipital groove that the long head of the bicep goes through. You also have the short head of the bicep that attaches at the coracoid process. So all of this is really important for you guys to get a good basis and foundation. So I would highly encourage you guys, make sure you're paying attention in anatomy right from the get-go, because you're starting off with bones, and where all those bony prominences and grooves and tubercles are is going to be important for later on when you learn the muscles, and you need to know where the muscles are attached. Okay, here is a good picture of the scapula. Okay, so we've got the inferior angle of the scapula, the medial border. This medial border will attach like the rhomboids that go to the vertebrae or the spinous process. You've got the superior angle of the scapula, the glenoid fossa, right here, the coracoid process. That's where the short head of the bicep goes. And on this side right in here is all where the subscapularis would be. If I had another, I don't. If there's a picture of the posterior aspect, you would see the spine of the scapula, and you see a little bit of it right here. But that spine of the scapula is really important because that's where it's going to help you identify where some of the other rotator cuff muscles are. Okay, next slide. We are looking at the different bursa sacs. All that green area is different bursa sacs throughout the shoulder. And how I explain it, I don't know what I just did here. Let me pause. Okay, let me go to this. So how I explain it to the patients is you've got your scapula, your clavicle, and your humerus. And for instance, say you only have this much space in between for the four muscles of the rotator cuff, the different bursa sac, the tendons, and everything to go through. If any of those get inflamed or swollen, it's not like the body or the bones are saying, here, let me give you more room. You still have that same spot. So that's why it ends up limiting some of that motion in there. We've talked before at length about bursa sacs and bursitis. You can get it in the shoulder. It's not as apparent as, say, the knee or the olecranon process, but it definitely does hinder that range of motion. They're not able to get that complete full end range of motion. Okay, on this is giving us a better look. This right up above has B, or I guess letter B, where we're looking right in on that glenoid fossa. The little green ones are where the different bursa sacs are. So depending on where there's friction or hitting, either of those can be inflamed or irritated. This is also a good picture to kind of see that labrum, and if this is kind of what I would talk about, the top of a T, if you were to put the golf ball on top of it, if it's been dislocated in the past, then you have a higher probability of that labrum being torn or stretched in that area, and there's a higher possibility for you to end up dislocating an additional time. Down here at the bottom, we're looking at the humerus right here. Just kidding. Right here is that epiphyseal plate or the growth plate. You've got more bursa sacs. You've got the supraspinatus tendon that's going through there, different glenoid cavity of the scapula. So there's not a lot of room for play in any of that. and going on the muscles, okay? So looking at the muscles, on the left side, these are more of the superficial muscles, the deltoid. There's an anterior, middle, and posterior deltoid. In the front, pec major, you've got the coracobrachialis. You guys have all hopefully have heard of the biceps brachii. Biceps, bi meaning two, so there are two heads. The long head goes in that brachial groove. The other one attached to the coracoid process, the brachioradialis that goes across two. And then over on the right side is more of a posterior view. And right here, just kidding. Right here is what I was talking about earlier, where the spine of the scapula, it will help you identify different muscles depending on where it's at. So up here you have the supraspinatus, you've got the infraspinatus, and the teres minor that all make up 3 of the 4 muscles of the rotator cuff. The other one is on the inside of the scapula, and that one's called subscapularis. Okay. Down here we've got our lats, latissimus dorsi. You guys have probably done lat pulls with a lat bar at the gym, so you can kind of use that for reference. In the posterior aspect of the upper arm, you've got triceps brachii, and we will go on from there. Maybe not. There we go. Okay. Another picture, this one, they've actually cut the deltoid off so you could see the muscles up underneath. Supraspinatus, why is this moving? Supraspinatus, infraspinatus, serratus anteriors down here, serratus posteriors over here. And then another picture looking a little bit more deep, and now you could see on the inside aspect of the scapula, you've got your subscapularis. Here is the acromion process out here. And then all these, we've talked before about brachial complex and having a stinger, where maybe somebody's head is forced into extreme lateral flexion, and these nerves are often stretched and give you kind of a numbness and tingling down to the lower arms. Okay, it's really hard for me to try and teach you guys this without our lab. If and when you take anatomy, you will have to know this brachial complex and what is involved in each of those things. I'm not asking you guys to have all of that memorized for this particular portion. Okay, and this slide is showing you where the subclavian, axillary, and brachial arteries are relative to the shoulder complex. And the bigger picture is just showing you an anatomical landmarks on a person. Okay, functional anatomy of the shoulder. There is a huge degree of mobility with limited stability. Okay, so the humeral head articulates with more of a flat glenoid. The rotator cuff and long head of the biceps provide a stability, and then the supraspinatus compresses the head, while the other rotator cuff muscles depress the humeral head when you're in an overhead motion. Okay. Prevention of shoulder injuries, making sure that they're doing their mechanics correctly is going to be ideal. Definitely go and talk with the individual coaches, see what that particular patient normally throws like, and if they're trying to fix anything. Make sure they're strengthening throughout the whole range of motion and not just in one plane. We want to make sure that it's in multiple planes. And you can make sure you're involving tubing exercises, but also working on your negatives. What the heck does she mean by that? Okay. I'm not going to throw because I suck. But using this picture is in your guys' book, where it talks about the wind up, the cocking phase, the throwing, the release, and then the follow through. Right there in D and E, that's where most of the injuries occur, because I've talked before to you guys about the mirror muscles, where everybody wants to get the muscles really big where they can see it in the mirror, and they aren't necessarily paying attention to the back. But when you figure, say a pitcher is throwing a fastball and they want to get into the 90s and 100s or whatnot, they've got it so amped up, but they're not necessarily working on the posterior cuff or your decelerator muscles or your negatives. So it's really important for them to make sure that they're strengthening the posterior cuff, because the posterior cuff is what's going to make the arm slow down. So a lot of times when they're throwing, throw, and they're unable to slow it down, it breaks down that kinetic chain, and that posterior aspect is usually the first thing to go. Okay, assessment of the shoulder, hops, okay. So we are asking all the different history questions. What happened? When does it hurt? Where does it hurt? Have you ever had any surgery? Observation, you're looking for any anomalies, any swelling, deformity, discoloration, scars. Palpation, we're palpating the bony prominences and then the soft tissue, and then we're going to the special test. But I've talked before about the shoulder being a ball and socket. So there are 9 movements of the shoulder. And this normally is where I would have you guys stand up in class, okay, and kind of do as Simon says. Because if I ask the athlete, okay, go ahead and flex your shoulder, you could get anything, okay? So with a flex of the shoulder, actually I'm going to have my daughter come here. Okay, I'm enlisting the help of my other daughter, AJ, and we're going to go over the 9 different movements. So I'm going to have you go ahead right here. You're going to flex your shoulder, so you're going to go all the way up. Okay, that's flexion. Go all the way back down is extension. Look here. Okay, abduction, A-B-D, like a child's being abducted. Abduction is away like this. Adduction is down like that. Okay, then you have internal and external rotation. So right here, she's at a 90 degree. She's externally rotating and then internally rotating. Or if she's here, she's externally rotating and internally rotating. Then you have horizontal adduction, horizontal abduction, and then circumduction would be like in a swimming. Go ahead, swim. Like this? Yep. Okay, and that's circumduction. Thank you. Okay, so I'm telling you guys right now, you're going to have to know those 9 different movements of the shoulder. Guaranteed. You're going to see it on a quiz or a test. Now we're going to go into some of the different special tests. Let me minimize this. Okay, so just know that there are a ton of special tests. I'm just giving you a broad overview introduction to this. So there's an apprehensive test, and that's both for anterior and posterior dislocations. There's a sulcus sign, there's a near, and a Hawkins-Kennedy. So those are 4 tests that we're going to go over, and I have pictures. You guys will learn that the apprehension test is to determine if there was a dislocation or a subluxation, both anteriorly, and a second one for posteriorly. The sulcus sign is looking for AC sprains or acromioclavicular sprains. Near and then the Hawkins-Kennedy are both for different impingement. Okay, so this next one is the apprehension test. So if I'm on the fence and maybe I don't know if they've actually dislocated in the past or they've said they felt like it came out but it went back in, I would definitely be using this. So A right here is just the clinician doing external rotation and applying a little bit of pressure right there. A positive would be if the patient jumps forward or grimaces or just feels like they don't like that. Okay. B is for posterior instability apprehension test, and all they're doing is the patient is lying supine. The clinician flexes their shoulder and applies a little bit of pressure on their elbow, so posterior pressure. And then the relocation test is C, where, I don't know if the little box is in your guys' way, but where they're doing an anterior apprehension test, and then they're just putting additional pressure to see if it's causing them or eliciting any additional pain. Okay, impingement. So A is Neer's test and B is Hawkins-Kennedy. Both are used to determine if there is impingement within those soft tissue structures. So either they're going to say that they have pain or they're going to grimace with that. And basically all that is, hopefully you guys can tell with A, is the clinician is just forcing her into adduction up at top. And then B, I normally will start the Hawkins-Kennedy down here in this plane and then move more in a frontal plane. The reason being is if they're having pain out here, they're definitely going to be having pain right there. Clavicle fractures. This is probably one of the most common fractured bones. It usually happens when somebody falls on an outstretched hand, or if they fall and their arms are in and they fall on the tip of their shoulder. So in younger adolescents, they'll end up getting a green stip fracture, where, if you don't remember, that is where some of the bone sticks together but the other part will flay off. And most of the time with these clavicle fractures, they're no longer doing surgery on these. And there's different guidelines for different hospitals, but they would have to meet a particular criteria of overlap. If there's a certain amount of overlap, then yeah, they might go in and do surgery. But for the most part, they'll give them a shoulder brace where it'll retract their shoulders and hopefully help lengthen that clavicle, and then they end up with just a bony prominent landmark where that fracture was. Okay. Direct blow, clavicle fracture, or they fall on an outstretched shoulder. This is an x-ray of it. You can tell it's very apparent where the fracture is over at B. And a lot of times what I encourage you to do, especially I find in football where they have their shoulder pads on and they're like, oh, my shoulder's killing me. Probably 8 times out of 10, it's usually ends up being some type of clavicle injury or fracture. So yes, I'll get to the shoulder, but then I'll walk my fingers up towards the clavicle and make sure I'm palpating the clavicle. If I feel any crepitus or movement, yes, we need to take the rest of the equipment off and do a further evaluation. And then down here, D is what I was talking about, a brace that they would put them somebody on, where it will help retract the shoulder blades. Retract the clavicle to help lengthen that. Okay, other fractures. Any of these fractures, we're still going to make sure we splint, treat for shock, and refer. Make sure when we're splinting, we're checking CSM. Humeral fractures, removed from activity for 3 to 4 months. I know it sucks, but it's a really big bone, and we need to end up allowing for it to completely heal. Proximal fractures is 2 to 6 months. Epiphyseal fractures or growth plate fractures usually are much quicker in healing, and that's about 3 weeks. Last fall semester, my 8-year-old didn't tell me the correct mechanism of injury, so I had waited a little bit longer than I should have, and we ended up finding out that she had a proximal humeral fracture just distal to the epiphyseal plate, and she basically fell on an outstretched hand. She had told me she was running into the tackling dummies. So mechanism of injury is definitely very important. Okay, acromioclavicular sprains or AC sprains. If you see down here in the bottom right, let me see if I can move that, but the bottom right, there are 5 different kinds. I'm not expecting you guys to know all different kinds, but you should know that it's the acromioclavicular ligament that's definitely causing that sprain, and will often have a piano key effect where they have more of a sulcus sign where there's that step-off deformity. Okay, subluxations and dislocations. So it's a good idea to try and find out what the mechanism of injury is. That way you can determine if it's if it's a posterior, an anterior, or an inferior dislocation. And then if it is reduced or not. Okay, we want to make sure that it's back in place. Anytime that you suspect that there was a dislocation, you need to make sure that they get an x-ray. So some subluxations and dislocations. This one is an anterior dislocation where the head of the humerus is moved anterior to the glenoid fossa, and you've got an x-ray right here to show it. There are a ton of different complications that can and do occur from these dislocations. You will have to, so there's a list of 7 different things. You need to remember and think of at least 2 of them, okay? With dislocations, yes, we're worried about rotator cuff injury, fractures, if the biceps tendon has subluxed, or if there's a transverse ligament rupture, but we're also worried about lesions. And what we're talking about with those lesions is the labrum of the shoulder, okay? So you've got your ball in your socket, and then that labrum kind of helps keep that ball in place, and depending on where it dislocates, you could have either a Bankert lesion, a Hill-Sock, or a SLAP lesion, which SLAP is superior labrum anterior to posterior. Okay, shoulder impingement. A lot of times with this, you have a mechanical compression of the supraspinatus, subacromial bursa, and the long head of the biceps tendon because there's not enough space in that coracoid-acromial arch. Okay, we see a lot of this in overhead repetitive activities. So what sports would that include and entail? Okay, hopefully we're thinking baseball, softball, think of tennis when they're serving the ball, same thing in volleyball. Think of swimming and overuse in swimming and water polo, or even basketball, okay? So any of these. Some exacerbating factors are if there's laxity or inflammation, or if the shoulder's not aligned properly anyways. Also, it's good to know what type of posture they have, if they're kyphotic, kind of like that hunchback, and rounded shoulders, which, unfortunately, today's generation is having more and more problems with because we're so used to being on our cell phones and media and getting what's called text neck. Okay. So that's going to wrap it up. Nope, almost. Biceps rupture. Okay, so right here, hopefully, we can tell that there is an anomaly or a defect right there. Okay. Usually it's going to be because of a powerful contraction. It's going to be stereotypically more towards the muscle in that bicipital groove, but it can happen anywhere. And we're finding more and more often that the biceps rupture is going to be more middle-aged men, but again, it can happen to any population. Okay, so elbow, going over the shoulder. Elbow, what kind of joint is the elbow? Hopefully we've said a hinge joint. It opens and closes, or it flexes and extends. Getting into some of the elbow. So we're going to go over anatomy, functional anatomy, all that stuff, but think of what questions we're going to ask for the history. What are we looking for in the observation? What are we palpating, and what special tests can we do? Okay, so the elbow, we're looking specifically at the humerus, the radius, and the ulna. Okay, so now we're looking at the distal end of the humerus because we're not at the shoulder, we're down towards the elbow, and we're looking at the ulna and radius and where they articulate. So with the humerus, you've got the capitulum and medial and lateral epicondyles. And then on the ulna, you've got a crinoid process and the trochlear notch, tuberosity of the ulna. And then on just lateral to that is going to be the head of the radius, the neck of the radius, and then the tuberosity of the radius. Okay, what that looks like. So to the left, we are looking more at the ligaments and the bursa sac. The olecranon bursa, when somebody lands on a hard surface, whether, concrete, skateboarding, or the gym, if they hit that olecranon bursa just right, they'll end up with bursitis. And it looks like they have a softball on the end of their elbow. They won't be able to fully, completely extend and flex their elbow, but it doesn't cause a ton of pain. It's just annoying. And then to the right, you guys are looking at different muscles. Okay, so we went a little bit about the biceps, the triceps on the upper arm, biceps brachii, brachioradialis, brachialis. And then now in the forearm, we've got the inconius and the supinator. Okay, supinator, what does that do? Hopefully we said supinate. Okay. This is just a good picture that's in your guys' book. The yellow obviously is the nerves, red is artery, and the bluish purple are the veins. And each of these run deep. And I've told you guys, if I come across an elbow dislocation, I'm not comfortable reducing it just because of the nerves, arteries, and veins that could be pinched and so many things that could go wrong, and I don't want to make it worse. So I would splint them and send them. And then this last picture, just like in your guys' book, just shows anatomical reference on a person's body. Okay, so functional anatomy. It's a complex that allows for flexion and extension, and then the forearm is the pronation and supination. Okay, there is about 145 degrees of flexion, and what stops that is going to be soft tissue. It's going to be muscle on muscle. And for extension, we should have 0 degrees. Some people are hypermobile, but what's stopping that? That's a hard end fill or a bony extension. So for pronation and supination, that's at the forearm. So remember before, we're holding supinate, we're pouring that soup out, we're pouring it out, okay? What we're also looking at is a carrying angle, okay? In females, it's 10 to 15 degrees, and in males, it's much less. It's 5 to 10 degrees. So with that carrying angle, and I think I have a picture coming up, but that carrying angle, if they're in anatomical position, I'm not tall enough, and it's going out in line, there's a little bit of an angle. So this is what we're calling our carrying angle. So females have a larger carrying angle than males, and that's just our anatomical structure. And then for the special test, really there's only 2 special tests for the elbow, and that's the valgus and varus test. Okay, valgus, there's an L in it, so we're applying lateral pressure. Okay, so we apply lateral pressure, and we're testing that medial collateral ligament or that ulnar collateral ligament. Okay, you got your ulnar collateral ligament and your lateral collateral ligament. You're probably used to hearing baseball people talk about UCLs. Okay, there's actually 3 different bundles of that ulnar collateral ligament, and most common what's torn is that anterior bundle. Okay, this is the picture that's in your guys' book. You can tell there's a little bit of abrasion here. It's starting to get more of a bursitis. I've seen it where it's much larger. So something to take note of. Ulnar collateral ligament sprain. So this injury is a result of a valgus force from repetitive trauma. So a lot of times our pitchers are having a lot of that valgus force that's stretching that UCL. Some will have Tommy John surgery, or they'll have the nerve transection to either help minimize any type of tendinitis that happens in the elbow. Elbow dislocations, okay, usually going to be because they've fallen on an outstretched arm, and it's pretty much a guarantee. Every time I've worked a wrestling tournament, we've always had a elbow dislocation of some sort, if not multiple. Okay, now we're getting into the forearm, wrist, hand, and fingers. Okay, So we're still going to ask those pertinent history questions, observation, we're comparing bilateral, we're palpating bony and then soft tissue, and then we're going into some of those special tests. So now we're looking specifically at the radius and ulna. When we're in anatomical position, the radius is on the lateral aspect. Then we're going down closer towards the wrist. In the forearm, on the anterior aspect, you've got your flexors, and on the posterior aspect, you have your extensors. I would take a little bit longer to kind of note and look at each of these. There are blood and nerve supply, again, that we've talked to you about. It's more deep. Most of the flexors are supplied by the median nerve, and the extensors are controlled by the radial nerve. So radial and ulnar arteries, the blood is supplied, but the nerves, if there is some type of breakdown in the nerve or impingement, it's definitely going to affect one side more than the other. And these are where the muscles look at in variance to on top of, an adult or human. Okay, this is the bones. So just similar to with the foot, your thumb only has two phalanges, your proximal and your distal phalange, whereas digits 2 through 5 have a proximal, middle, and a distal phalange. So right here, this joint is going to be the DIP joint. DIP is distal interphalangeal joint, and right here is the PIP. The long bones in our hand are metacarpals, and then down here we've got our wrist bones. Okay, and to try and differentiate and memorize, there is a mnemonic. Okay, you're gonna laugh at me. I can't believe I'm video recording this for all to hear, but this is what's helped me. And with that, let me see if I can clear it. Okay, so we're gonna start on the thumb side, proximal, and the yellow is the proximal, the green is distal. So you have S, L, T, P, T, T, C, H. What the heck does she mean by that? Okay, I'm going to tell you. So, some lovers try positions that they can't handle. Ha ha ha, I know. But this will help, and I'm telling you, you're going to remember this. So on the thumb side, proximal, you've got your scaphoid, your lunate, your triquetral, your pisiform. Then going back up here, trapezium, trapezoid, capitate, hamate. Some lovers try positions that they can't handle. And then looking at the next slide, this is just showing there's a ton of different articulations and ligaments that we're worried about. The most common fractured carpal bone is going to be the scaphoid. Oops, that's not what I wanted. The most common fractured carpal bone is going to be the scaphoid, but the most common dislocated is going to be the lunate. Okay. When we get down into looking at the smaller individual muscles, again, on the palm side, you're going to have your flexors. On the dorsal side, you'll have your extensors. Looking at the different ligaments, it's going to be apparent that anatomy is one of the basis and foundations of athletic training. Okay. So before, we've got our nerves. and radial nerve, ulnar nerve, median nerve. And then up here on the dorsal, we've got our extensor retinaculum. Okay. Looking at the arteries and veins. So you guys hopefully remember when we've done vitals, we check our radial artery, 3 major nerves, ulnar, median, and radial, and the ulnar and radial arteries supply the hand. Okay, this is what it looks like in looking at the tendons on top of an actual person. Okay, there's a couple special tests specifically for the wrist and hands. One is Finkelstein's test, and this one is testing for de Quervain syndrome, basically where the patient makes a fist with the thumb and it's tucked inside, and then you ulnar deviate. Positive sign is going to be that you have pain and indicates tenosynovitis. Pain over the carpal tunnel could indicate carpal tunnel syndrome, or we could do the Phalen's test, where we have them put the palms of their hand or the dorsal part of their hand back to back and leave it there for about a minute. Pain will be produced in the region of the carpal tunnel, and we're finding that a lot more with people that don't have ergonomically correct workstations or specifically at their computers and don't have that little wrist rest. And then for the wrist, hand, and fingers, we again have the valgus and varus stress tests that are testing different collateral ligaments. Okay, we've got fractures, all kinds of fractures, right? So up top left is a radius and ulna fracture. You can see that there is a joint where there's not supposed to be a joint. Bottom right looks more like a Colles fracture or Boxer's fracture, where it's the 5th metatarsal, and we end up having athletes with this, and then they try and lie to us and say, no, I didn't punch a wall, or I didn't punch my locker, or I didn't punch Billy Joe Bob. But that's pretty much a fair indication of how and why you end up breaking that bone. Colles fracture is on the lower end of the radius and ulna, so the distal third, and usually it happens from falling on an outstretched hand. I've had it sucks, it's not fun. Don't recommend breaking any bones. Scaphoid fracture, which I've talked about before in the wrist. Scaphoid is one of the most common carpal bones to be fractured. What we're worried about that is when it doesn't heal properly. Okay, so it has poor blood supply, and if it's not healing like it needs to, then it runs the risk of you potentially having to have a surgery to kind of fix that. Wrist sprains, it's really common wrist injury, arises from any abnormal force or movement, whether it's flexion or extension, and occasionally we're worried about it disrupting the blood supply distally to that, so we need to make sure we're checking cap refill and that their fingers aren't going cold. Okay, tendinitis, inflammation of those tendons, and we've looked before at the anatomy, and there's a ton of different tendons. So more common is flexor carpi radialis and ulnaris, where we have repetitive pressure on our palms, like when you're holding onto a bicycle and cycling. And then carpal tunnel, so Phalen's test, carpal tunnel. So right here, you've got that transverse carpal ligament. Just kidding. You've got that transverse carpal ligament. Maybe I can draw. Transverse carpal ligament, and that median nerve is going through there. So when they're having a ton of pain and don't necessarily know why, it could be that maybe one of the tendons are swollen and putting a lot of pressure on that median nerve that causes that numbness and tingling that's not pleasant. Okay, ganglion cyst. Okay, back in the day, not recommending this, but 15, 20 years ago when I was taught how you would get rid of a ganglion wrist is you would have the patient put their hand on the table and get a phone book. I know, right? Who has those anymore? or an encyclopedia and slam it down really hard on their wrist. Okay, we don't do that anymore. Usually they'll end up alleviating on their own, or the patient can go into the doctor and they can figure out what's going on. But when you feel that ganglion cyst, it's not stuck on a bone or anything. It does have movement. So that's how you can tell the difference between, a ganglion cyst, or somebody actually came and thought they had a ganglion cyst, but it was their lunate was dislocated. Okay, ton of different finger injuries. There's different finger splints. Again, you need to be in the know about different rules and regulations for different sports on whether or not they can wear any of these. And then a ton of different rehab for different parts of the upper extremity. I am not doing it justice by any means, but I will give you a couple of slides just to talk about some of the things that we can do. But just note that in and of itself, rehab can be a whole course on its own. So here we've got the clinician, it looks like, doing different joint mobs to help with mobility of the shoulder, of the scapula, and helping maybe break up any adhesions or scar tissue underneath. Flexibility. Flexibility is key. If we can teach our patients how to stretch, whether it's self-stretch or if they're in a team, have them partner up with somebody that they trust and they can work on their range of motion and flexibility, that will do them world of wonders. And then you don't have to go to a gym. You can go to whatever you have. Right now we're in quarantine and gyms are closed. So, at home maybe you have cans of soup. You can use cans of soup instead of these dumbbells, because it doesn't need to be extremely heavy. When people, like when the MLB guys are doing I's, Y's, and T's, they're not going heavy. It's usually less than 5 pounds. So any of these that you can do, and then if you throw a TheraBall in there, you can make it more dynamic and work on the whole body. Plyometrics, okay? We're used to talking about plyometrics specifically for the lower extremity, and it's a little bit more difficult for the upper extremity. Lower extremity, whether it's box jumps or hurdles or whatever the case may be. Upper extremity, she's lying down, she's throwing the ball up in the air and catching it. So the catching is more the plyometric. B, she's throwing up against a wall. C, if you have the capability or have a trampoline that can go at an angle, that yellow ball is a weighted ball, and you can have them aim for a particular part of the trampoline and then it'll come back at them. Not everybody has the trampoline, so you can go in D, where the person is not intentionally like being a upset big brother, little sister thing and throwing them into the wall, but gently tapping them or pushing them where they don't necessarily know what direction it's going to be in. That way they can kind of come up on a push-up from that wall. Neuromuscular control or proprioception, we can have them on a TheraBall. This BAPS board is more of an ankle rehab, but you can make it work for shoulder also. You can have them Cinderella style and start waxing your floor. And then D, I don't know if you can tell, but the clinician is going to be tapping the person's shoulder to help maintain their stabilization. Again, this was a really quick rehab part. I just wanted to get more of the generalistics of the upper extremity to you guys. Okay, that being said, this is about an hour long. Make sure you don't have any questions. Feel free to call me or email me and we can figure things out. I hope everybody is staying safe and I hope everybody is well, and I will check in with you guys shortly.